My name is Fred Kate. I'm Vice President for Research, and I am delighted to welcome you to this Research Roundtable. We began doing these several months ago and focused on a number of issues, but in particular on our grand challenges. And they provide an opportunity for researchers working on the 3 grand challenge programs to talk with each other and to talk with other people who are interested about their work. It provides a great opportunity for people to build bridges, to figure out things you might be interested in joining or being part of. And we are so glad you could all be here today. Before I introduce our panelists, I want to introduce our real star for today, Dean Robin Newhouse. Robin Newhouse is Dean of the School of Nursing, distinguished professor, and she is the person who really gave birth to this grand challenge on the addictions crisis and has been steering it so ably over the past 3 years. So Robin, let me give the floor to you.
Well, thank you. I am more than delighted to welcome you to this presentation. I'm very excited to hear about the progress and the impact that the PIs from the Addictions Grand Challenge have achieved. So I'm so thankful that you're here. And today we're focusing on the research conducted by particularly 3 PIs from the Addictions Grand Challenge. And just to remind us that the whole purpose and aim of the Responding to the Addictions Crisis Grand Challenge was really to deploy IU, Indiana University's research strengths in a public health emergency with many partners across the state. So that's important because these are critical issues that are facing the people of Indiana. And so this is research with an impact. And the results of our effort have done more, far more than individual products or research results. We have built IU's capacity to respond to public health emergencies by funding teams of faculty, undergraduates, graduates, and other students and postdocs that have been involved in this research that will go on to future careers with a great experience. We have invested in infrastructure such as the extension of community health outcomes by which we can now reach people in the rural communities and those that we couldn't reach before to educate and engage in different problems that they're experiencing in the clinical arena. 49 grants have been submitted by our investigators, and so far $23.4 million have been awarded as subsequent grants to these projects. In addition, we have engaged numerous community members, 160 partners across the state, 101 unique partners in 34 counties. So we've had a far reach and engagement across the state as well. It's also important to say that we also released some stigma reduction focused videos and training material for the general public. It's called In This Together, that has now been used nationally. We've had over 400 people take advantage of these modules that train them and help them understand addictions. And there's also a module for people that want to have discussions in the community. So beyond the investigators, there's been a lot of work behind the scenes that we're very proud of. Now, I would also say Dr. Peter Embi, Dr. Hank Green, and Dr. Kosali Simon research, they're going to demonstrate the impact that they've made, and it's impressive. I know you'll enjoy this because it is a clear demonstration of how we are battling substance use and substance use disorders in the state, and they have impact not only with individual patients, but organizations and our policymakers. And I'll stop there and let you proceed, Fred.
Robin, thank you so much. You know, I'm reminded, another thing that you have done is worked with organizations across the state to do naloxone training. And I see I have my naloxone here in my desk drawer, well prepared by you. So I'm really very grateful for your leadership and for the work that's been done in this grand challenge. So I'm going to quickly introduce our 3 speakers. I'm going to do this alphabetically, and we will proceed at least initially alphabetically. And this is something of a test of my ability to know the alphabet. All 3 are good friends, and it's an honor to have them here today. Peter Embi is the president and CEO of the Regenstrief Institute, and he has a bunch of other titles: Associate Dean for Informatics and Health Services Research at the School of Medicine, and Associate Director of the Indiana CTSI, and Vice President for Learning Health Systems at IU Health. But suffice it to say, he is a key leader around the world in the issue of data in healthcare and the role that information and information technologies can have in improving healthcare. And his work with the grand challenges on the Indiana Addictions Data Commons, and I'm hoping he'll talk more about that in just a moment. Next, I'd like to introduce Dr. Hank Green. And Hank is an associate professor in the Indiana University School of Public Health, Department of Applied Health Sciences on the Bloomington campus. And he is director of research for the Precision Health Initiative's person-to-person health interview study, another grand challenge here, and then a PI on a grant that's part of this grand challenge, the Indiana Network of Prescribers of Opioids and Related Treatments Import. And so I hope very much you'll talk about that, Hank. And also, let me just make clear, everyone knows you were previously at the RAND Corporation, where many of us know about the consulting work they do, but not so much about the academic work they do. And he was senior behavioral scientist there. And finally, I'm delighted to introduce Kosali Simon. Kosali is the Herman B. Wells Endowed Professor at the O'Neill School of Public and Environmental Affairs. She recently became Associate Vice Provost for Health Sciences on the Bloomington campus. She's an economist recognized really throughout the world with many leadership positions and awards. And we are delighted to have her here today to talk about her work, her particular Addictions Grand Challenge topic, opioid addictions and the labor market, hiring and training during an epidemic. So Peter, let me hand it off to you. The three of you, without further introduction, again, with the basic question, tell us a little about your work related to the Grand Challenge and what motivated you to do it. Like you all have hundreds of other projects, lots of other opportunities. Why this? And I'm really interested in that. So Peter, the floor is yours.
Thank you, Fred. It's great to be here with this great group of good friends and colleagues. Yeah, this is, I think we'll probably all say some variation of a similar thing, which is that, you know, the whole area of addictions and being able to address this crisis, I think is the primary motivator. There's so much that needs to be done, so many people that are suffering and need our good work, our research and the like. And what I focused my career on as a physician informatician is really on figuring out how we can better leverage data and information and technology to be able to really empower the research that needs to happen in order to make those discoveries and be able to improve the lives of individuals and populations. And so when the Grand Challenge was announced, my team and I immediately got to work thinking about how we could contribute. And we realized that because we have a history of really a lot of excellent capabilities and data sources and data repositories, but they were somewhat fragmented and needed to be pulled together, that there were common needs. And rather than seeing that happen sort of on a project by project basis, while that's certainly important to do for certain reasons, there was a need very clearly, I think, to pull together a data commons and to do that in a way that not only enabled the use of state-of-the-art technologies and capabilities, but also addressed what we all know is often the biggest challenge with doing these things, which are issues of governance and a lot of the relationships that need to be built upon and established in order to do this. I like to joke that we are like so many other places, we have many silos of excellence, and we want to be able to overcome those whenever we can to be able to unlock the potential and access to the data. So the birth of the Indiana Addictions Data Commons was really driven by that desire to bring together vast clinical data assets that we have with social determinants of health, with other exposomic data, and then be able to continue enhancing that, working very closely across various partner organizations, which I'm happy to talk more about. But that was really the initial motivation for it.
Thank you very much. And do you mind just saying one more word about what is that project doing?
Yes, sure, of course. So what we've actually done is we've done a number of different things. So we had an aim first on really establishing a governance structure to be able to bring the right people to the table that are currently responsible as stewards of data assets across the university, across our partners in not only academia but also in government. And the health systems in order to be able to understand, what's already in place and how do we augment that. The core focus is really to bring these data together, but recognizing that a lot of the ways we do that is not simply through sort of some creation of a large central database, although that is very, very powerful. It's also to create a federated network of data assets. And so what we've done to date is we've established that governance structure. We've done a lot of work on really curating and characterizing the information, and I can put a link in to a metadata browser where people can actually see the different data assets. There are 16 different core data assets, many of which have now been integrated and some of which remain in a couple of other areas for good legitimate governance reasons. But we also put in place a data concierge so that we could enable access to the data in a way that was a lot easier for people to navigate rather than each individual investigator or end user needing to sort of try to figure that out on their own. And then we've continued to augment the data, harmonize it, and add to it with our partners. And now, in addition to enabling a number of studies, there have been dozens of studies that have been enabled with the resource and the like. We also have been working on more front-facing access to the data with dashboarding and other capabilities that we will be rolling out. So that's, again, I could say a lot more about it, but that's kind of a high-level summary. Oh, you're on mute there, Fred.
I suspect everyone on this call does know, but this is what Regenstrief is really world renowned for. We rely on Regenstrief data in all sorts of other areas, and so it's terrific to see this strength brought to the addictions challenge as well. Hank, the same questions to you. So what are you doing and what's motivated you?
Well, thank you. First of all, I just want to thank everybody that's on this roundtable for, I think, recognizing and enabling us to have access to this sort of large-scale data, because really, for me, and I think for a lot of other people that are listening and that are on this roundtable, has vastly enabled the kind of research that we want to do and that we need to do in order to move the needle on public health in Indiana. So first, let me say thanks to that. But so what brought me to my project was that I've been working on at the sort of intersection of health behavior, substance use, and social networks for over a decade. And I've been sort of aware of, after coming to Indiana, I became aware of the sort of significant addiction-related and opioid addiction-related problems. And that there had been significant problems with access to medication-assisted treatment, which is a pharmaceutical approach to treating opioid addiction. And having lived in Los Angeles and done substance use-related work and outreach there, I was aware of the benefits of it as a therapy alone or in combination with behavioral therapies. At the same time, in parallel, I've been working on a study that used a large database of medical claims data to understand the uptake and the diffusion of another pharmaceutical-related treatment, but it's a prevention for HIV. And sort of at the same time, when the AGC call for proposals came out, I was like, well, what can we learn about the uptake and diffusion of MAT prescribing among physicians here in Indiana that could use a similar type of sort of claims data analysis approach. And the reason that using claims data is beneficial to us is that surveying that number of healthcare providers would be nearly impossible, but the traces of their behavior live in these claims in a way that help us to understand their professional connections with each other and their choices. So my study takes the large-scale Optum claims data set that we have access to now, or at least a certain portion of it, and it explores what factors can be used to predict the likelihood that a provider in Indiana will prescribe MAT to a patient. So we are predicting an individual prescriber level behavior, and this includes doctors, physician's assistants, nurses, so on and so forth, everybody that's able to prescribe. What characteristics predict that? Is there something about their own specialty? Is there something about the patients that they're seeing? Is there something about the network of connections that they have among each other professionally? Is there something about the area that they're living in? Like, are there county level measures of access to treatment facilities, access to AA and NA meetings, so on and so forth, that predict this? And to sort of give you the bottom line up front, the really cool thing for us is that actual contact with another MAT prescriber is a very strong predictor that someone will become a prescriber, even in light of all of these other factors that we're looking at. And hot off the presses from analyses that we just finished yesterday, that's also a really great way to get somebody to become an MAT prescriber. So if we're thinking about policy changes that we can make that can encourage access to MAT around the state, this gives us a great deal of ideas for how we might develop sort of strategic communication and peer-based interventions, right? And that, for me, is really great, because one of the things that we found, and I'll just end here after this, one of the things that we found is that in our data, in that Optum data for the years that we were looking at, half of the counties in Indiana do not have a single provider that is prescribing MAT. So that means that for people who have opioid use disorder in any of these counties, they have to travel at least to an adjacent county, in some cases 2 or 3 counties away, to get access. And I believe that one of the great ways for us to move that needle is to try to find a way to sort of increase that availability. And I think that the analyses that we're doing can help us come up with great policy changes there.
Great, thank you very much. And let me say, I think this issue came up in the community advisory board that Robin chairs, that we have as part of this, where again, mayors from local communities are talking about the challenge of how far people have to go and how do they get there. I mean, it's not just, it's not always a case of hop in your car and drive down there. Hank, just before we go on, and Kosali, you may also want to jump in on this, but say just a word more about the Optum database.
Well, I think Kosali is probably a much better
well, you can say why it's wonderful, and then Kosali can say why she led the charge for it. So.
Well, you can see right in what Hank's describing of these insights that are fantastic databases.
Yeah, so the Optum claims database is a longitudinal database that's at the medical claim level that incorporates a great deal of information about the medical care delivery process, right? It's all completely de-identified. It's even de-identified at the level of the prescriber. So we can't tell who is. It's all about just understanding the patterns of behavior that are involved in this particular database. And it's for us to understand how healthcare systems work and how we might be able to improve their effectiveness and their efficiency, right? That's ultimately is my goal, right? And the amount of data is phenomenal. The level of detail is beyond what we would be able to have in almost any other way without the support of Indiana University providing it for us and researchers like us at the School of Public Health and the Sociology Department at O'Neill, you know, at the medical school and so on and so forth. I don't know, it's been such a boon for me because I would never have been able to do this. I mean, I would have spent years just getting the data that I needed if I had to try to do it on my own. So it's just a blessing.
That's great. And what a wonderful lead into Kosali, who did lead the charge to get the Optum database. So please, Kosali, first of all, tell us about your work on this grand challenge. Tell us about what's motivated you to do it. And then by all means, tell us more about the Optum database. I know that's a compound question, sorry.
Excited to be here. I just want to add to what Hank has said, that thanks to the Addiction Grand Challenge, now the Optum database is available for all IU to use. Get back to that after talking about, you know, what it is that motivated my work. And just to say from the start, it's just really exciting to be with you all and to be in this discussion about how data enhances our ability to answer pressing questions, because I think that as a health economist, that's what really motivates my work in all areas. So I was not a researcher who had been studying addictions, crises at the start, right? My initial, what pulled me into health research as an economist was looking at the things that state and federal governments, local governments were doing, policies to try and enhance access to healthcare for vulnerable populations, and looking at programs like Medicaid and Medicare and what that meant for healthcare access, health outcomes, and all other aspects of life that is affected by healthcare access. So I had studied health insurance policies, the Affordable Care Act, of course. And about 7 years ago, I started to be more aware of, thanks to actually fantastic students that we have. It's through a student who was working on these topics about 7 or 8 years ago, that my eyes were open to what, even at that time, was not yet a very well recognized area of research. And I saw the scope for bringing tools of economic analysis to studying the impacts of policies, to being able to say, we're not going to be able to run randomized controlled experiment to see how one policy works at addressing an issue compared to another, but we can use statistical techniques to see whether policies have causal impacts, and to be able to have this evidence base so that when other states want to enact policies, they know. So what drew me to being able to, to take the power of these large scale databases that are available, to have geographic identifiers, to be able to merge in policy variation and to say, what is it about what states are doing that is being effective, and what might actually not be effective in policies that have a lot of promise behind them. Just because something sounds great, when it's actually implemented, sometimes it doesn't work through. So I'll describe, one of the studies that we've done as part of the Addictions Grand Challenge, my colleagues, including Dan Sachs at the Kelly School, Alex Hollingsworth at the O'Neill School, and others who've been part of this project, we looked at the impact of some very promising new state laws that were restricting prescriptions to few days, the 7-day laws, for example. So that was a law with a lot of promise that said, if we were to make all opioid prescriptions for new users only have a few days, then maybe we will reduce prescribing and problems that will come about from it. So we went in really hoping to find good results. What we found was that actually those laws have led to more prescriptions. So certainly there's a reduction in the long prescriptions, but there's a large increase in short prescriptions. So somehow the intention didn't work out. So in total, the opioid prescribing has actually gone up, the total quantity of opioids. So this is the kind of evidence that, and we've used the Optum database for this because it's very fast turnaround. We can be looking at data that are otherwise going to take years for other standard data sets to be able to have, because these were laws that have been very recent. We've got enough of a post period to do this. And these are the kinds of things we need to have more and more evidence on to know which are the policies that are working to reduce opioid prescribing. But the other area that state policy, federal policy can really influence, as Hank was alluding to, is the ability to upscale the availability of treatment options. So we've been looking at the workforce, policies that might increase the access to the workforce. And this has been with a data source that has almost all job postings in the US. So it's called the Burning Glass data, and it's together with Cuddy Borner at Bloody School. And we have access to all these job ads so that we can tell where the demand for workers is going after policy change. So we look at the Affordable Care Act and we say, we know that it increased certainly access to opioid use disorder treatment, medications and services, but what has it done to how many people has it brought into the workforce? And we find that there hasn't been an increase in the workforce from these policies, which suggests somehow that there's more than just insurance expansion that needs to occur to increase the number of people who are able to prescribe and provide treatment. So these are new areas that we're going into. We've also pivoted from towards COVID from this work, and we've recently published the first evidence of what's happened to buprenorphine treatment during COVID, finding that even though there was buprenorphine treatment had been increasing And that increase has stalled during COVID. But thanks to changes in telemedicine laws that happened during the pandemic, there hasn't been a fall in buprenorphine prescribing as there has been for other types of prescriptions.
So this is a really amazing stuff to hear. And I want to say, I think probably everyone on this webinar already gets the point about the importance of data. But I think it's worth asking you to just come back to, you've each described the type of data you're working with and what you're hoping to get out of it. But there's also sort of a residual question. So, it appears that a lot of the country doesn't care much about data, that, that they're really not interested in the science on COVID or the science on addictions or the science on whatever, and particularly in the policymaking sphere. And so I'm interested that you three, as major internationally recognized data researchers, how do you see this playing out? In other words, is the research you're doing having that I mean, I know you're making transformative discoveries. Is it having a transformative effect, or how do you remain optimistic that it's going to? Again, we can do this in the same order. Peter?
Sure. No, happy to jump in first. I'm very curious to hear what my colleagues will say.
Yes.
So I get the easy part. I can start. No, I think you raise a really, really important question that obviously I don't think any of us have fully have the full answer to. But one of the things that we have learned, we've learned so much during the COVID pandemic. But one of the things that certainly has become even more clear than it was before is the importance of being able to communicate effectively with a very broad sort of constituency about what it is we're learning and what just really science communication, which is not a new thing, right? I mean, we've known for quite some time that we have to do a good job and a better job increasingly of how we do that. One of the areas in which I think that intersects with data is data visualization and being able to make that very consumable and very easily understood and accessed by the general public. And that and doing that in a way that provides that kind of if you will, counter to whatever prevailing misunderstanding might exist or other messaging might be there. And I do think that's part of our role as academics and as experts, is to be able to lay out the facts as they are and be able to sort of describe their implications in a way that is understandable to various populations. So one of the things, for instance, that we are actively working on right now is building on our growing experience and expertise across the university is interactive dashboards for a lot more of this kind of information. And as we do our research, the research immediately informs what it is we then might want to display and how it is we want to communicate that. Because I think, yes, for the general public and for our colleagues in the media, but also, as you say, for our policymakers and others, I think it's very important to be able to put that kind of information front and center, and that can be very, very powerful. So we're starting, for instance, with one of the things we've done is we've merged our clinical data. We know that not all the data we need to understand this is coming from clinical data and health system data, but we have that. And then we've worked very hard to merge that with, for instance, data from the state, from the Management Performance Hub and other data sets, for instance, to link emergency department visits with EMS runs and be able to really understand what's happening there. Be able to better characterize what's happening around different subpopulations. And so we're creating cohorts around different populations of interest, including the intersection between what, as Kosli alluded to, what's happening during the COVID pandemic and that intersection with what's happening in the opioid crisis. And we will be putting out some interactive dashboards. So I do think that's a part of how we begin to address this. But I think this, this communication question is a really, really important one. So now I'll hand it to my colleagues to continue.
Great, thank you. Hank or Kosli?
I can jump in first. I can't reiterate more strongly what Peter said about information visualization, like coming up with really great, clear, easily understood graphics that communicate these kinds of findings, I think goes a long way towards at least reaching lay audiences or maybe not expert audiences. I should preface this by saying I'm an anthropologist by training, and so data was initially anathema to me. Like, I had no interest in data, but I came to understand that in order for me to answer the kinds of questions that I wanted to answer, I needed to be able to get my hands dirty and start doing the kinds of analyses and using this data And it really has just broadened my sort of ability to answer the questions that I want to answer. But I always come back to, how can I tell a story about the results of this model that will be a hook into the policymaker or the population or the medical care providers in a way that sort of really brings it home to them. So I believe that an effective way to do that kind of science communication is to ally good qualitative research, which many of us do that are on this call, with quantitative research. And I kind of think sometimes the magic is in finding the great stories that really reiterate the kinds of sort of findings that you're trying to communicate with your models. And the innovation comes in finding ways to combine data sets in innovative ways. So Peter has talked about putting data sets together in unique and innovative ways. Kosali has talked about pulling things together in unique and innovative ways. And the same thing goes for me. I mean, this is not just based on analyses from the Optum data. It also includes data from SAMHSA. It includes data from the Indiana State Department of Health. It includes data from the census, and it even includes data from other grand challenges. So there's tons of opinion data that comes from the Precision Health Initiative person-to-person study, and another project that is part of the Addictions Grand Challenge that explores people's attitudes towards opioid treatment and addiction and medication-assisted treatment, that all sort of fold into my ability to run these analyses and then create stories that I think really help communicate this. And, you know, even something as simple as a map that shows what counties have and do not have access to a single provider of MAT can really do, as my major professor used to say, it helps people to pass the interocular percussion test. Like, you show them a map and it hits them between the eyes. Like, that's exactly the kind of thing that we need to be able to do. And, you know, that involves sort of a savvy application of data to sort of more broad communication.
Okay, so Kosali, you're an economist. You're not going to be able to say you came to data late or you were skeptical of data.
But, you know, I think our profession has not done a great job of communication as economists, right, who have been studying data for, you know, since the start of economics. It's been about getting insights from data. But if you look at what journal articles look like until very recently, it's all just statistical output. So exactly to just emphasize what's been said, making the story interpretable, visualizing is the word we're using, but contextualizing it to a local setting too. So I think we have a lot to learn from journalists, where we think about, you know, it's about the story, right? It's the human element. But you can also see how journalists have become data scientists. You look at how the New York Times reports a story, there's a lot of data behind it, but they're telling it in a very approachable way. And so I think the more we take as lessons from that, how do we put a local context on it? How do we get the story and then use the data just to back, you know, it's the backing up. It's not just here's a ton of results and then I'm gonna, you know, tell you how to interpret. It's what are you interested in? What's the concern society has? Here's how this helps answer it.
I will just add, as a parenthetical to that, I can remember showing up before Congress to testify on something like data privacy and credit reporting, and I could give lots of numbers and charts and graphs, and then the next witness was someone who lost their home because of an error in their data report, and I was sunk. Like, there was nothing I was going to do to recover from that person who had a compelling personal story to tell. And so again, I'm just joining your chorus of saying, combining the data with the compelling story so that you have a narrative really seems like an enormous value of both your work and this grand challenge more broadly, to kind of give that solid research foundation, but also humanize the research. Let me ask one more question, and then let me say to everyone else participating, this is a good time if you have questions to enter them into the Q&A function, and then we will see that those questions get answered, or as many of them as we can before our time is up. Kosli, I'm going to start with you because you mentioned COVID, and I'm just curious, I think we're all curious about the impact of COVID on this really important work that you're doing. And so has it added, has it shifted? And I might just also add, do any of you have data on how COVID is affecting people with addictions challenges? Kosli, let's start with you.
Okay, so to start with, I think COVID has just opened our eyes to the need, not just for big data, but timely data. So we have become accustomed to saying, well, we want to make sure the data are really vetted before we do anything with it, and that the surveys especially go through a lot of vetting. So we usually get them about 2 years later. Right? And we have done policy analysis on that basis of we'll wait till the data come and then we'll do the analysis. But then we're only commenting about, oh, you know, it's just so late that we are not getting into the immediate changes that need to be happen. So I think right from exactly a year ago, you know, that changed right away to we just need information, understanding the limitations of what we're looking at, that it's early stage and we're not going to be able to get the full story. So also many places that there are, you know, vaults of data that are commercially available that are used that researchers don't often get access to. And so there was both the need for immediate data and many of these data for good programs that were announced that I think have led to us expanding, we're not just relying on, you know, the government sources of data, but it's coming at us from so many places. And so this is a very exciting move that I'm curious to see how it extends beyond the COVID period, how we're going to be using all of this to inform our decision making. So these are things many of my colleagues and others, you know, have just pivoted towards trying to be bold with newer sources of data that at first it might feel like is high risk, right? And I understand, especially in junior careers, you have to be very careful of, you know, go with known sources. It's risky sometimes to go with these very new, unsure, you know, what's sampling for, what's the universe of that kind of setting. But I think there are many benefits to many minds being put together to distill information from new sources of data. I don't know if that answers the direction.
No, very, very helpful. Hank, do you or Peter want to jump in on this, or?
Sure. One thing that I think is really sort of to follow on with what Kosli says, our ability to take that up-to-date data and sort of respond in an agile manner to sort of the changing face of public health needs, I think is, that goes hand in hand. And, one thing that I've learned through this whole process is like there's been this massive increase in sort of a desire to be collegial and to really focus on solving the problem rather than on necessarily just doing the research for research sake, if that makes any sense. Like I feel like everybody is willing to say, this is what I've got, what have you got? Let's see what we can get if we can put it together. And that has been a very different thing for me. That's been a very great experience in the past year or so in the context of COVID. So
I agree with everything that's been said. I think the collegiality is a great word. COVID has certainly been really wonderful in that regard in terms of really, crises like these bring out the best or the worst in people, and they're certainly brought out a lot of the best in our community across the university and across the Grand Challenge. And the Grand Challenge itself being focused on another crisis, right, on the addictions crisis, and then layering on top of that the COVID crisis. I think it's only amplified the need for all of us to look around, figure out where other expertise exists. I mean, the truth of the matter is we are so there's an embarrassment of riches in terms of the incredible expertise we have across the state and certainly across IU. And it's really allowed us to identify a lot more of that. For instance, one of the things that that actually Coastly and others have been involved in, is this Indiana Pandemic Information Collaborative that we started, where we've brought people together across all the sectors to really address, because of the need for this rapid cycle, rapid response. We got to get bureaucracy out of the way. We got to make sure we're not duplicating effort because nobody has time for that. And we got to make sure we're addressing important things. It was an all hands on deck exercise, and everybody sort of checked their agendas at the door and got together and said, how are we going to make this happen? And I think that kind of thing, we continue to talk about it at the leadership level. That kind of thing is going to carry forward to help us with this. The other thing I'll say, back to your original question, is we're still analyzing the data, but I think unfortunately we have seen that during the COVID pandemic, there has been a worsening of some elements of the crisis in certain sectors. And so, you know, that's another thing that the further analysis and visualization of the data is starting to tell us. We're still looking at it, but then to Coastly's point, we know we have to sort of start sharing this information sooner than later, but there is a lot of information there that needs to be analyzed in order to really understand and characterize the changing face of the epidemic. And here I'm talking about the crisis, the addictions crisis. What is really happening, and what do we need to do to pivot? And that's going to require ongoing assessment and analysis as things get, you know, back to normal.
Well said, and obviously very important work. Lisa, I see questions are coming in. So let me turn to Lisa Fukuda, who is the operations manager for the Responding to the Addictions Crisis Grand Challenge. And maybe you would be willing to hand those questions out so that we make sure we get answers.
Sure, absolutely, Fred. Many thanks to our panelists for joining us today. This individual, they're bringing up an interesting and an important topic related to stigma, really noting that someone who is suffering from substance use disorder, really what they need is community support, empathetic physicians, more research on what types of MAT would work for their particular addiction, acceptance of addiction as a disease, particularly in the workplace. So how would someone who has substance use disorder directly benefit from the big data projects and outcomes that you all are talking about today? Hank, maybe do you want to take?
Sure, I was just about to jump in and say, you know, everything, we like to have a sort of theoretical framework for lots of our research, and I sort of think about MAT or other sort of opioid use therapies as this sort of triangle of access, availability, and utilization, right? So availability really has to do with, is there enough MAT out there for us to use it? Utilization really has to do with the patient deciding that they're motivated to initiate using it and that they're going to continue using it. And access really, I feel like, lies with the provider. And the focus of my research is on finding ways to increase access. And that is, how do we develop interventions that combat stigma at the provider level, that teach them the skills to start this conversation effectively without making the patient or the client feel stigmatized, and provide them with the tools that they need to understand the data for their area, to understand the need for their area, and to just recognize that, you know, their assessments of what someone with opioid use disorder looks like are very, very different than truly what that person does look like. You know, lots of qualitative research shows that providers are concerned that if they start prescribing MAT, then the face of their waiting rooms, you know, for lack of a better way to describe it, the face of their waiting rooms is going to change. And the reality of the situation is it's going to ultimately be no different. So my work focuses on creating strategic communication strategies aimed at providers to open the door to access for these people so that they don't feel concerned about going to talk to their providers, or if they do, that they know who to go to that's in their area that they can access. So that's sort of my perspective on what's going on and how this is going to change, how my data analysis and my results are going to change the behavior of providers to open the door for individuals here in Indiana.
I think it's very well said, Hank. And I'll just, the only thing I'll add to that is that I think there's such a need for more of that kind of research. And I think the other benefit to these data assets that we've pulled together and are making available is that more of that kind of work that then can illuminate where we're doing it well, but also where we're not and what needs to change, and then be able to inform changes in practice so that, to the questioner's question there, so that we can actually make sure that the way that care is delivered is more empathetic and appropriate and actually more effective. That's an opportunity to do that kind of health services research type analysis and determine. And we were talking earlier about communication to the lay public, but this is also a critical piece. I can't emphasize enough what Hank was saying, the communication to the provider community as well. And that will be helped with data. We're a little better at that, I think, probably in terms of at least having an audience in the provider community that generally is more, not universally, but generally more accepting of evidence and data in terms of changing practice and behavior. And then there are other levers we can pull. So I think the data can and should help us, but there's also a need to really accelerate and do that more, that kind of research to a greater degree and more aggressively.
Lisa, do we have another question? I want to make sure we get in all we can.
We do have one more question. And this individual sharing a personal story. As the mother of a teenager who struggled with addiction, she was struck with how few treatment options there are for people younger than 18 in Indiana, noting that they actually had to send her out of state for treatment. So the question is, again, maybe with the theme of access, how will your work with data solve this type of problem? And are teens comprising a large percentage of substance use cases? Kosali, would you like to start?
Yeah, I'll mention, again, going back to policy and data analysis, how this, what's being described as really large lack of treatment options is just, that's a pervasive problem. So even within the Medicaid system, there were rules from way back when, well-intentioned rules that in one specific case, it's called the IMD exclusion, got this long name, but what it means is that residential treatment for substance addictions disorders could not be paid under Medicaid. So states started to change that policy. And we recently did an evaluation of how changing this access, changing this policy leads to more treatment, right? And so it's being able to show that kind of evidence that will help other states say, oh yeah, we didn't know that there was this policy that's really restricting treatment access. Now that's one very specific insurance provider area, but it's evidence like this that will say to maybe on the payer side, extend coverage. And then if payers extend coverage, will there be then more treatment options that come up? There's also a lot of policies about regulating quality because you also want to be careful of the new programs that are coming up. So it's a very complex area, and data will help decide, what does the evidence show on the initiatives that are taking place.
I'm sure Dr. Newhouse may want to add a bit more here too, because obviously we are but a subset of all of the investigators and scientists working on the grand challenge. But certainly there are colleagues of ours that are very focused on the pediatric population, the younger population of individuals who are affected by addiction. And I know, for instance, we have colleagues like Matt Alsman and others who are doing work on looking at the intersection of that with the justice system, making sure that we have the kinds of that we have a learning system that actually says, look, when we deal with these youngsters who are addicted in a certain way, they have better outcomes, and there are better ways to do this than we might be in all of our areas. Here are some best practices. Here are some areas that need improvement. The data help to inform and evaluate what's happening there and be able to actually then provide the evidence needed for that kind of change. But it is a complex issue, and I guess sympathize and certainly would echo what's been said, and really thank the person for the question. I'm sorry you've been through that, and we should have more options for your child and for others.
Robin, do you wish to jump in on this, or anyone else?
No, I wouldn't say anything more than Peter said. I think the only thing I would add is the state certainly has a database that one can search treatment options, and it describes treatment options at a very high level. Now, these are data that I think have sort of standard kind of information, but it doesn't always answer the question, are these treatments appropriate for me? Are they offering treatments by people that I want to see? Is the treatment comprehensive? Does it have people that can provide medication-assisted treatment plus comprehensive care? Is there a social worker there, et cetera? So these kind of data that Hank and Peter and Kosole are talking about actually can be very useful to add to databases like this so that tools can be developed so you can actually seek treatment in areas that are a preference to you. So I just want to add that that's another great portion of a contribution that these big data have to helping people find the right treatment at the end of the day.
We probably also should mention the great benefit that the expansion of telemedicine is going to provide for access to these types of treatments. And I mean, truly, what an amazing change to allow access for people who, you know, may be hundreds of miles away from treatment options in some cases.
Right, well said. And I think it also, all of these comments highlight something which I just would like to make sure we don't lose sight of here, which is the type of analysis, the data analysis is useful at every level. In other words, it may help the legislature adopt better laws. It may help regulators and service providers extend service more effectively. It may change payment policies, but it can also help local communities. It can help a local business decide how to deal with this. It can even help a family have the information they need to understand where the resources are, what's happening, and how they can obtain those resources. And so one of the things, again, I'd like to say on behalf of the university is how grateful we are, all of us, for the research that you and your colleagues are doing throughout the Grand Challenge, but that are empowering at every level as we deal at every level with the challenge of addictions. Now, if you'll allow me, I'd like to take just the last minute here to just shift gears and do something else that is important. And that is some time ago, in fact, 18 months ago, before the start of IU's bicentennial, the trustees decided that as a key way to celebrate the bicentennial, they were going to create a bicentennial medal that would be awarded by the president to recognize, and again, I quote here, a distinguished and distinctive service in support of Indiana University's mission as a public university. Recipients, according to the trustees, are to, quote, represent the best of the university's rich history and to serve as role models for future generations. And today, it is my pleasure to be, on behalf of President Michael McRobbie, awarding the Bicentennial Medal to our colleague and friend, Kosole Simon. We have waited until this point, 18 months we've waited, hoping for a time we could be together in a large celebratory gathering where the president could present this in person as he loves to do. But unfortunately, COVID has managed to slow that down. And even though we seem to be doing better and we're very excited about the days ahead, we were worried that we would be getting closer to our tricentennial if we didn't go ahead and make this presentation today. So the president has given me the medal to present to you, which if this were Hollywood, I would hand it down the Brady Bunch picture into your hands. But thank God this is not Hollywood. We do something more important. It comes as well with this beautiful scroll that I have worked all morning not to drip on, which has been quite a challenge, as well as with a letter from the president apologizing for his inability to be here to present it in person. So let me just say on my own behalf, you know, there's an old adage, if you need something done, give it to a busy person. And that seems to be the mantra that Kosole lives by. She is unbelievably productive as a scholar and a teacher, as a member of our community, as a family member with a house full of children, and has been an amazing and unflinching supporter of these efforts we've been talking about today, and to my knowledge has never dropped a ball. And so she is one person you don't have to worry if she says she'll do something, it gets done. So I've introduced her once already. I don't feel the need to repeat all that, but I am really delighted to be joined today by the Dean of the O'Neill School, Sean Mooney, who I think would have some additional words to say. And so Sean, the floor is yours.
Thank you so much, Fred, and the Office of the Vice President for Research, and thank you so much for organizing this fantastic event today. I'm just so super proud to see Kosalie recognized for her outstanding contributions to Indiana University, and I'm so proud that she's a member of our O'Neill School of Public and Environmental Affairs. I can only really echo what you've already mentioned. Since she arrived at the school in 2010, Kosalie has been an omnipresent force as both a teacher and a researcher. And as you mentioned, Fred, her accomplishments over the past 11 years have been absolutely extraordinary, making her a perfect recipient for the Bicentennial Medal. I will say, a few years ago, one of Kosalie's colleagues joked that there must be 3 of Kosalie. I actually think that that might be an underestimate, and I'm wondering if there's secretly 5 or 6 Kosalie, and perhaps we need to talk about that at some other time. But you do so much. You are so amazingly productive. When you look at her CV, it's really just quite astounding. Her record of scholarship is as impressive as it is long, and she really is an absolute superstar. I couldn't be prouder to call her both a Hoosier, a member of IU, and also a member of the O'Neill School. So in addition to all her teaching and research, Kosalie has also served in many capacities for professional organizations like the Association for Public Policy Analysis and Management. And also she continues to serve in a variety of editorial roles. She also serves in Fred's office and does a tremendous amount for the school. I wonder actually if you ever sleep, Kosalie. I'm so impressed. During the COVID-19 pandemic, Kosalie and her colleagues really have just continued to put out scholarship that's really unparalleled in its timelessness and its scope, its timeliness and its scope. And she's done this all whilst caring for a significantly robust family, a lot of activity going on in Kosalie's home life. And I know that her husband, Dan, has also been really supportive in that area. And really, when every single minute of the day is stretched to its maximum capacity, Kosalie still finds the time to serve as a mentor, both to students and to faculty and her other colleagues around campus. So with that, Kosalie, I'm just really delighted that Fred is presenting this medal to you today. And I just want to say congratulations from me and from the school, and ask if you have a few words that you might like to say.
Oh my gosh, I'm still trying to pinch myself and say this is real. I'm really speechless and so humbled by this. I'm incredibly grateful for the opportunity to be part of this university. It is just such a supportive and an environment. I couldn't imagine a better one. It's just so, it's a caring university. It's everyone just goes about trying to do the best they can in support of the state and the community in ways that I'm just truly just so grateful to be part of, and just really can't believe this has happened. So I'm just I'm very, very appreciative. There's so many people who deserve the recognition. So I can only say, you know, we all do our part, and thank you.
So thank you, Kosalie. Let me say we are enormously proud of and grateful to all of our researchers, and we have the good fortune to have many amazing colleagues throughout the university, but I think they would all agree you are someone special. And so again, thanks very much to everyone who joined us today. Thank you, Lisa, and your colleagues for organizing this, and Robin for your leadership of the entire Grand Challenge. We are so grateful. Sean, we're honored to have you join us for this presentation. And Peter and Hank, thank you again. Kosely, congratulations, and I will drop these off at your house later this afternoon. Take care. Have a good day, everyone. Bye-bye.